why don't we move on to Jeff Fowler, Thinking Beyond the Clip, the role of transcatheter mitral valve replacement.
All right. Thanks, Hummel. Thanks for the introduction. So we just heard a lot of really good data about the success of TEER, and even looking at patients who are lower risk and comparing it to the surgical outcomes. But what we didn't hear is that there are challenges to TEER, and some of the anatomical complexity of the mitral valve do make it challenging to place TEER, and some patients aren't candidates for TEER. And so with that, there's hope that a transcatheter mitral valve replacement may actually be able to treat a larger group of patients that have that increased surgical risk but aren't candidates for TEER. Of course, there are challenges with TMVR as well, and so we're going to talk about that and see sort of where we're left here at the state of things at this current time. So the challenges with TEER really go down to the complex mitral anatomy. Of course, we know there is a heterogeneous etiology of MR. We saw a lot of data about primary MR. There's also good data for TEER in degenerative functional MR as well. Functional MR, but the anatomy can limit our ability to use TEER. So if you have patients who have small annulus or high resting gradients or mixed disease with mitral stenosis as well, placing a mitral clip on that valve becomes much more difficult at getting that great result with low mean gradients. Other anatomical features like thickened leaflets, the chordae, calcified leaflets with concomitant MAC, multiple jets or clefts, large coaptation gaps, and even though we're getting much, much better at this, sometimes visualization during the procedure can limit our ability to get sort of those great results that we're looking for. And so there's really hope that TMVR, or a transcatheter valve replacement, can overcome some of those challenges. And so what we'd really like to see is a device that can be agnostic to MR etiology and will perform in real-world anatomy, including those patients with MAC, small annular sizes, and mixed disease. And ideally in the least invasive method possible, which is likely going to be a transseptal delivery system. So the transcatheter mitral landscape right now has just exploded. This is a slide from TCT just showing all of the different devices that are under investigation at this time, with multiple different methods using both edge-to-edge repair, direct and indirect annuloplasty, a whole host of mitral valve replacement devices, as well as looking at the subvalvular apparatus as well. And so there's a lot of devices under investigation, and there's challenges with these devices. And so we need to find a device that can adapt its designed to fit a multitude of these anatomical variations. We've talked about small annular sizes with MAC, but the annular size is quite large in the mitral space, and anchoring these devices appropriately while minimizing paravalvular leak and getting adequate seal is important. And so you can see in that top graphic there's been multiple different methods, from tabs to paddles to apical tethers, to try to both anchor and seal these devices appropriately. And these large devices have to be packaged in small catheters in order to be delivered in the least invasive way possible to help these high-risk patients who aren't surgical candidates. When we look at further anatomical challenges, LVOT obstruction, or the so-called neo-LVOT that's created once the device is in place, is another large consideration here. There are different anatomical features that make this more challenging, including the anterior mitral valve leaflet length, asymmetrical septal hypertrophy bulging into that LVOT diameter. The aorta mitral angle plays a large role in the size of the LVOT afterwards, as well as device-related concerns, including device protrusion or flaring that's necessary. And so we've gotten really good using our structural CTs to overlay a so-called virtual valve in there and look at how an individual patient's anatomy will be impacted by the device that we're implanting there, and try to gauge what would be the complications that we may see, or whether there is adequate space for one of these devices. There are several different devices that are currently under clinical trial, and it's a really exciting time right now. And my point in putting this slide up is just to show you the different variations that are out there as far as the valve design and its, those features trying to anchor and seal and, provide adequate solutions for multiple different anatomies. And under randomized clinical trial, there are pretty strict inclusion and exclusion criteria for each of these different patients. And so we do see right now that we're having a little bit of some challenges getting these patients into these clinical trials to evaluate them with relatively high screen failure rates that are predominantly related to anatomical variations, and just looking at how these devices perform in each one does become a little bit more of a challenge. But I think despite these challenges in the design and engineering, the deliverability, the wide-scale applicability to different anatomical variations, there's a lot of patients that really stand to benefit from a good TMVR solution, one where they're too high of a surgical risk and they don't have a great TEER option. Having a transcatheter mitral valve replacement is going to be an important part of this. And so we're excited about trying out these different devices in the clinical trials, seeing how patients do. And what we're seeing in sort of the early feasibility and pilot studies is that these devices perform really well. So this is data on 5 different devices showing their residual mitral regurgitation, and you see good durable results. Sort of Conrad was describing that residual MR of less than 1+ or 1+ or less, and all of these devices show that significant improvement with durability, some of the top data there out to 2 years even. So let's finish with a case. This is a 76-year-old male who has an ischemic cardiomyopathy with an EF of 30% and severe functional MR. He's fully revascularized on good medical and device therapy, and yet has persistent NYHA functional class 2 to 3 symptoms. He's high risk for surgical valve replacement, and his anatomy is amenable for TMVR. And so he was enrolled at our institution in the Summit randomized controlled trial with the Abbott Tendyne TMVR approach. So the Abbott Tendyne is a transapical device that is a repositional and retrievable valve that's composed of 2 self-expanding nitinol frames and a porcine pericardial valve inside. You can see on the animation that's playing, the transapical sheath is advanced across the mitral valve. The valve is unfurled, repositioned under echo guidance in the appropriate position, and then there's an apical tether you can see in the top picture there with an apical pad to help both anchor and seal this device. And so this is sort of the intraprocedural imaging that we have of our patient here. You can see in the top panel the severe functional MR. On the bottom panels, we see the delivery sheath advanced across the mitral valve, and on the far right bottom panel, you can see the device is being unfurled in the annulus there. As we move to these beautiful 3D images taken by our excellent cardiac imagers, which you're going to hear from a little later, we can see the device protruded out of the sheath. Once it is partially deployed, we can recapture, reposition this, and place it in the appropriate place. And then the final pictures here show just a great result of a valve that's working well with no residual MR. The valve is anchored at the apex, and then the lateral thoracotomy incision is closed. This patient did excellent. He had no paravalvular leak, no MR, and a mean gradient of 2 on implant. He was discharged home within just a couple of days. And his 1-year follow-up, he had no heart failure admissions, persistent functional class 1 and 2 symptoms with no MR, no paravalvular leak, and low gradients. And so I think, what I'm trying to say in these 10 minutes is that despite the many challenges of TMVR, there are a lot of ongoing trials with different designs and different devices that we're trying. There is device iteration advancement that's happening, and even interventional techniques and tools that's going to help to place these devices in these challenging anatomy. And so I think what we're going to end up with at the end of the day is really a mitral valve toolbox, where we're not going to have one device that's going to treat all different disease types, but we're going to be able to continue to use TEER and different, maybe multiple TMVR devices to find a good solution for all of our patients. Thank you.